He will speak on noisy breathing in states. Spotlight on Stertor as a marker of upper airway obstruction.
Nice to be here among my friends and teachers, colleagues. Some of them I'm meeting after a decade. So it's nice to be here. Thanks for the invitation, Dr. Shankar. I'm going to talk about the Stertor pod. So airway starts from the nasal cavity, it's in the lungs, so till the bronchus. So wherever you have obstruction, you will have noisy breathing. So for example, if you have obstruction at this level, you will have inspiratory striker. If there are obstruction at this level, you will have expiratory striker. In between, you have biphasic striker. In case, if you have obstruction from here to here, in this area up to the supraglottic level, you will have stertor. So this kid, 2-day-old child, came with the abnormality in the ear. So you can see there is some amount of noisy breathing, and the voice is normal. I think the voice is still not coming. And see this, there is some amount of nasal flaring and chest retractions as well. So I started with the nasal endoscopy. The child is lying down. Started like this, going. You can see there is a coronal atresia on the left side. I'm not able to pass the scope further down. And then, so I'm coming to the other nasal cavity. I'm going now, and here I'm able to see the middle turbinate, and then along the floor. Remember, the floor is up. Okay, the child is lying down, and I'm going down. So then the posterior one-third of the tongue is being pushed down because of the retrotrachea, and because of that, there is a epiglottic collapse. And the epiglottic collapse is not only the problem. You can also see there is some amount of pharyngeal collapse because of the narrow oropharynx there. And then if you go further down, you will be able to appreciate there is some amount of arytenoid and arytenoid collapse, aryepiglottic fold collapse. But the vocal cord movements are fine. And you can see there is some amount of subglottic edema here. And if you go further down, there is a little bit of tracheomalacia as well. So the noisy breathing is not due to one single area where there is obstruction. The obstruction starts from the nasal cavity till the carina. So that means you need to be very careful in evaluating all these patients, because there is some indication for you that the abnormality in one ear. So that keeps you in alert to make a clear diagnosis of every single area in the eye. So this time, so listen to this noise. Okay, it's stertor, but you can pick up something more on that. So if you watch carefully, there is minimal hot potato voices also there along with that. So that will give you a clue what is going to be there in the supraglottic level. You can see there is a similar laryngomalacia. It's like a fish mouth. There's no doubt. Okay. So laryngomalacia diagnosis is made, but there is a hot potato voice. Why there is hot potato voice in laryngomalacia? Because there is something sitting above it. Okay. There is a lingual thyroglossus cyst which is there, that is giving this noise of hot potato voice. So I'm coming to pediatric OSA. So pediatric OSA, so lot of things have been spoken about. Kamran has spoken beautifully about the post-tonsillectomy persistent snoring. So what is the indication for the surgery in the first time. So in case if you select the right patient, then maybe you can reduce the persistent failure rate later on. So how do you do that? So what we do is we give a simple questionnaire for every single patient outside when they are coming to the clinic, and we read that and document that, and then bring the patient in, because nowadays getting just a history from the patient is very difficult. So we started doing this, and then do the clinical evaluation. Clinical evaluation is so important. First of all, for the youngsters, you will have to make the children sit properly and in the lap of a parent, the good position. Otherwise, you will not be able to see anything. And second thing, use a proper metal tongue depressor. Don't use this fancy, wooden spatula. So that is not going to give you any extra information. And do a proper examination. You will see the tonsil, and also you can have some idea about the adenoids. So when the child is crying, obviously the soft palate has to go and approximate with the pesonal rate. If that is not happening, there is something behind. Then you have a clue. Then you can obviously do a transnasal flexible laryngoscopy if you want, and home sleep videos, sleep study, dice, and all sorts of material. So I'll come to that a little later. So here the home sleep video. So there's a clear, objective features. So what we do is we ask every single patient to come with the weekly once sleep video, and we analyze all the 4 videos after 1 month. And what happens? So there is no improvement. Okay. So this is the prerequisite. First, you will have to confirm the child is having clear OSA before taking up the child for surgery. And the next is there any associated part which is causing the obstruction or any other contributing factor. So nowadays the fancy thing is about adenoids. The post COVID, we are seeing a lot of patients with adenoid enlargement, maybe because of increased number of allergy. That is one part. Another thing is maybe because all the people are now having everything in their hand, in cell phone, they are reading about it, they are thinking that adenoid is a disease. So every single day, patient will be coming to you telling that my child is having adenoid, and we have recently diagnosed that he has got adenoid, and we have also taken an X-ray which says grade 3 adenoid, grade 4 adenoid, so we want a surgery. So are you going to do surgery for these children? Now, you need to be very clear about adenoid is not a disease. Adenoid is a normal structure in the body. What is it causing? Is there any biofilm formation, or is there any enlarged adenoid which is causing OSA or orchitis media with effusion? But again, people will be coming to you saying that he's got type B tympanogram and he's got some fluid, but normal here. Do you do surgery for them? And evaluation of symptomatic adenoid hypertrophy includes clinical examination. That is so important. And again, nasal endoscopy if needed. Radiology has got very, very limited role, because everybody is coming with the X-ray, and some of the pediatricians are taking X-ray to see if there is any reduction in the size. Every month we will be taking some 3 X-rays, 4 X-rays. They will be coming to you with 4 X-rays of saying that the adenoid was there. Then we have been following it up with serial of X-rays to see whether it is reduced or not. What is your problem? There is no symptom at all. There is no, OSA. There is no problem. Even if the adenoid size is bigger, what is your problem? Even we were children, we used to have adenoids. Have anybody taken X-rays to see the size of the adenoids? No, because there is no symptom. So you need to give importance to the symptoms and also the clinical examination. And treating symptomatic adenoid hypertrophy surgically is reserved only for those who fail maximal medical therapy. When there is classic, allergic rhinitis, then you cannot do surgery straight away. Treat allergy, see if there is improvement in the symptoms. So now we are also doing a prospective study with the home sleep videos of the parents with questionnaire 18 and Monash scoring, and we are going to publish it later on. to say that this child is having OSA and this child is improved with medical management, this child doesn't need any surgery. Or those children who failed, something like this. See this. This child has got snoring, sitting and sleeping. So here you don't need any other evidence. Okay, you don't have to look into the adenoid by taking an X-ray. The child is clear cut. Okay, you will have to go ahead and do the surgery. It doesn't matter what the age is. The child is only 2 years old. Doesn't matter. The child cannot sleep otherwise. Do the surgery. And see, by examination itself, you are able to see there is a huge tonsillar enlargement. Obviously, there will be adenoid. So you don't need any other investigation. For example, if the child is having obesity and adenotonsillar hypertrophy, what happens in this particular case? We generally, what we do is send the patient first to a endocrinologist to evaluate any hormonal abnormality for the obesity, and then weight reduction, and simultaneously you treat the child with medical management based on the condition. And sleep video recording, ask them to do the video recording, and ask them to come after 4 weeks with the videos and anti-allergic management, obesity evaluation and reduction. And sleep study, who are all need sleep study? This is the IPOG consensus on sleep study. Those who are less than 2 years or no comorbidity, then there is no need. In case if less than 2 years with trisomy 21, any visual abnormalities, 100% of the respondents say that they go for polysomal therapy. Obesity, yes, 96% of the people will go for sleep study. So that means you don't have to do sleep study for every single patient. The best way is to do a home sleep video recording, because everybody has got a smartphone and you can record and assess by yourself. And after 1 month of conservative management, see this child is improved. And with a good proper weight reduction, this child doesn't need any adenotonsillectomy. So this is the reason you will have to have a proper indication to go for surgical management, so that you can avoid a persistent recurrence even after the surgery. But what about this child? This child has Blount syndrome and adenotonsillar hypertrophy. The orthopedician sends the patient to me because the anesthetist doesn't want to give anesthesia for this child because of the OSA. So I saw the patient, and as a routine, I sent the patient to endocrinologist to evaluate. Then the orthopedician called me and said, he's got Blount syndrome. That means we need to do the correction before the epiphyseal surgery. So you need to do the surgery immediately. So we have to take up that risk and doing the surgery without any evaluation, and then they have to do a orthopedic surgery, then child became all right. So you need to tailor-make your plan for the surgery. So this child, this is a Dijah syndrome, and there is Stertor. And also, if you notice, there is no proper voice. So that means there is something else. See that? The problem is the type 3 glottic bed, because the Dijah syndrome, the 22q level deletion, there is a high chance of glottic bed. You need to give importance to the voice and then plan accordingly. Otherwise, if you straight away go and give anesthesia for this child, then you will land up in problems. Then the child will crash on the table. So when you are evaluating the glottic bed, you need to see whether there is any subglottic extension before planning any surgical procedure. So this child, there is Stertor, but it's high-pitched Stertor. That again has to give you some other, idea for you to do a scopy. See, when you are doing the scopy, you see there is a supraglottic collapse, okay, and also there is a pharyngeal collapse. All right. So you can make a diagnosis of laryngomalacia or pharyngomalacia. Okay. See the pharyngeal collapse. But if you do the scoping further down carefully, you can see there is a movement of the vocal cord which is paradoxically moving. Your anesthetic is shouting from outside, inspiration, 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 and you watch there is a so the paradoxical movement of the vocal cord during inspiration, the vocal cord is closing. Okay, so that means the child is having a bilateral vocal cord palsy. So see this child. Some supraglottic collapse you can see, but there is something more like a stertor because of the noise. See that? So there is a laryngomalacia and pharyngomalacia. See that? The whole pharynx is completely closing, collapsing. So that is the reason the noise is more of a stertor type. So laryngomalacia and pharyngomalacia. See this child. Again, some amount of corporeal voice, and you can see there is a huge bulge in the retropharyngeal space. Okay, so in this particular case, we don't need any imaging because this child came with the scan. Because by examination, if you do a proper examination, you can see there is a retropharyngeal space abscess, and then do the abscess drainage, and you can see the postoperatively immediate improvement. Okay, here you need to get the history. The child is having some problem, fever, and acute episode. So obviously, it can be only retropharyngeal abscess. So to conclude, adenotonsillectomy is a treatment of choice if you have right indication. And airway endoscopy is the gold standard, not the radiological examination, because this is a both static and dynamic assessment. Always best to do a scoping to see what is happening inside. So this is our conference, CPAC 26, going to be happening in September 4 and 6 at Chennai. So there are around 10 international faculty coming for the conference. I want all of you to attend the conference and get the benefit of those experts who are coming all over the world to teach us. So thanks for the time and thanks for everything. Thank you.
You do the theater stuff or you do it?
Publicity, allows, but I do all the scopes in theater. So because that's why I call this job airway endoscopy. Because every single case is different. You don't know what exactly you are going to do. So I take the patient to the theater, even if I don't give anesthesia, I just start with the scoping to see the dynamic assessment of the nose, nasopharynx, and the oropharynx up to the supraglottic. So further down, if I want, I can spray and go down, deepen the anesthesia. If necessary, I can convert it to general anesthesia to see is there any posterior laryngeal cleft or something like that to probe and see. All those things can happen at one particular one group. So if you do the airway endoscopy in OPD, if you don't know the diagnosis earlier, maybe you will come up saying that the child is having laryngomalacia. The child may also have tracheomalacia. Then you will have a problem in taking up the child for surgery. And also you are branding the child with one diagnosis. And the child will be going around with the same diagnosis everywhere. So that you can prevent by doing that. But post-operative assessment, or in case you have a slight doubt that the child is having adenoidal enlargement or not, but the child is having severe symptoms, it looks like adenoidal enlargement, but the symptoms are not correlating with that. Then I'll do one flexibiloscopy to see. At that time, if I don't have a microscope, I also take a lateral view X-ray to know whether the adenoid enlargement is correlating with my clinical assessment. Only for that.
Wonderful presentation.
Thank you.
Thank you.
Sir, nice presentation, sir. Actually, we have one such case where the child, most of the child with bilateral vocal cord paralysis present with some noisy breathing only during sleep. And most of the time in the daytime, the child will be normal and as usual prepared for adenotonsil, but we suspected something else when we saw that the sleeping video of the child. And when we did a FOP, it was a bilateral vocal cord paralysis. And then when we did all the evaluation. It was the patient was having bilateral vesicular schwannoma and multiple meningioma and attached it as an NF2 case. So I think this airway endoscopy is very important. Even we cannot label it just like that. It's a case of adenovirus.
That's why you should have some idea even before taking a child because of the noise. Even during sleep, you take the video. The bilateral overcut palsy will have high pitched stridor, so you will not miss that out. Okay, if you have slight doubt, what I do is before I do a surgery, I start with the scope. But before intubation, I ask the anesthetist not to intubate the patient. Do one scoping, see is there anything else, and then if you are sure that there is no other problem, will get another problem. Then intubate and do the surgery.
Thank you, sir. Very nice.
Thank you very much, Steven, for that very good presentation. It brings in your mind a lot of different thoughts. So I think one of the main take-home message would be the younger the patient, the more indication for an airway exists. And number two, the more the symptoms does not fit into any single clinical that you have learned up to or seen up to. That is when we should come to airway exists.
Thank you so much for that.